Okay. The last chapter that we're going to do in this section is chapter 33, Miscellaneous Pain Medications. Introduction. As we know, pain is a subjective finding. Not one person is going to be the same. Some people will have a higher pain tolerance than others. So you just have to go off of what your patient is telling you. Migraine headaches are the inflammation and vasodilation of the cerebral blood vessels. Medications that are used prophylactically. So this is going to be to prevent from migraine from coming on. This can be used your beta blockers, your anticonvulsants, your TCAs, and your estrogens. Abortive is going to stop a migraine that has occurred. So your first line of treatment is going to be more of your non-specific analgesics, such as your aspirin-like medications and your migraine-specific medications. So, for instance, your serotonin receptor agonist, which is your triptans. And then your second-line treatment that they can use are the ergot alkaloids. And then local anesthetics block the motor and sensory neurons to a specific area. Okay, so first we're going to talk about prophylactic treatment, beta blockers, propranolol or Inderal. The action is going to prevent inflammation and dilation of those intracranial blood vessels and relieving the migraine pain. Prophylactic therapy to help prevent a migraine headache. Complications that can occur: extreme tiredness, fatigue, depression, asthma, exacerbation. So you're going to have to be careful with people that have COPD or asthma because it could exacerbate this and make it worse. Bradycardia, hypotension, so make sure that you're monitoring your vital signs, the heart rate and the blood pressure with this, and then have them check the heart rate prior to taking the medication, and notify the provider if anything significant has changed. Contraindications: pregnancy risk category C, heart block, bradycardia, bronchial asthma, cardiogenic shock, and heart failure. Precautions: other antihypertensives, liver or kidney impairment, diabetes mellitus, Wolff-Parkinson syndrome. This is in the heart. It's very rare. Kids have dropped dead on a basketball court from Wolff-Parkinson syndrome. It's just a change in the EKG in their heart pathway. Interactions: verapamil, diltiazem, diuretics, antihypertensive medications, and insulin. Okay, so your first line treatment is your aspirin-like medication, so acetaminophen, Tylenol, NSAID, so your aspirin, naproxen, Aleve. Excuse me. Action of this is to prevent that inflammation and dilation of those intracranial blood pressures, once again, relieving that migraine. Therapeutic uses is abortive therapy to stop a migraine after it begins and after prodromal manifestations has start. So they have those, those auras that occur before their migraine actually starts. Complications: bone marrow suppression. So you make sure you need to monitor their CBCs, platelet counts, and then observe for any bruising, bleeding, fever, sore throat, and they need to notify their physician. Gastrointestinal distress. So they may have abdominal pain, ulceration, nausea, vomiting, diarrhea, constipation. So they need to monitor for the GI bleed. So coffee ground emesis, which they would get that if they're throwing up. And then bloody or dark tarry stools. If it's a lower GI, the coffee ground is going to be an upper GI. And then abdominal pain. They can take this medication with food, milk, or an antacid to help. And then myocardial infarction or an MI or stroke. So you need to monitor their cardiac status to get a baseline, especially for those older adult clients and clients who have a history of cardiac disease. Interactions are going to be your antihypertensives, furosemide, thiazide, diuretics, oral anti-diabetes medications, corticosteroids, alcohol, tobacco, oral anticoagulants, lithium, other NSAIDs, thrombolytics, antiplatelets, and salicylates. Then your serotonin receptor agonists, your triptans. This is your supatriptan, which is Imitrex. That's a very popular one. I'm sure many of you have heard of it. Its action, once again, is just to prevent that inflammation and dilation of those intracranial blood vessels. It is also an abortive therapy to stop a migraine after it begins and after the prodromal manifestations have started. Complications, chest pain. So typical chest pain, heaviness in the arms, tight chest, pain into the jaw, down the arm. Some of them may complain in the back, and some numbness. They may be feeling nauseous. So typically a lot of these adverse effects are self-limiting and not dangerous. Notify the provider if it continues or the chest pain becomes more severe. Coronary artery vasospasms or angina. So people who have or are at risk of coronary artery disease should not take triptans. Dizziness or vertigo. So avoid anything that needs driving or operate machinery until they know how the medicine's going to affect them. And it is a tetragenesis. So remember, clients who are pregnant or trying to become pregnant should not use this. And use adequate contraception because this is going to be dangerous to the fetus. Contraindications are pregnancy risk category C, liver failure, ischemic heart disease, history of MI, uncontrolled hypertension, other heart disease. Interactions are going to be your MAOIs, ergotamine, or other triptans, and then SSRIs. Okay, so then your second line is your ergot alkaloids. Ergotamine. Action is once again preventing that dilation inflammation of those intracranial blood vessels. It's used as an abortive therapy. GI discomfort, starting with complications. So administer an antiemetic, such as Reglan, which is your metoclopramide. Acute or chronic overdose, ergotism. So they will complain of muscle pain, paresthesias in the fingers and toes, peripheral ischemia. So withhold the medication and notify the provider immediately. Physical dependence. Do not exceed the prescribed dose. Do not take these medications daily on a long-term basis. Manifestations. They can have withdrawals from this medication. And the headache, nausea, vomiting, restlessness. And they just need to know notify their provider if this happens. These medications can cause fetal harm or abortion, so do not take these while pregnant, and then use multiple forms of contraception while taking these medications. Contraindications, pregnancy risk category X, kidney and liver dysfunction, sepsis, hypertension, pregnancies, coronary artery disease, and risk of MI. Interactions are your triptans, some HIV protease inhibitors, antifungal medications, microlide antibiotics, and grapefruit juice. So all classifications, do not use abortive medications for more than 2 days a week. Avoid any trigger factors. So if they know what triggers their migraines, then to try to avoid those. Have them lay in a dark, quiet place. Use antiemetics if they become nauseous or vomiting. And this is the Reglan. Check the heart rate before taking propranolol. So if it's less than 60, don't be giving it. They can take these with food to avoid the GI distress. Orthostatic hypotension, once again, having them change position slowly. They may, if they have a portable or if they come into the office, do a 3-way blood pressure on them. And then avoid any driving or operating machinery. Okay, local anesthetics. So your lidocaine, tetracaine, procaine, yeah. Procaine, which is your Novocaine. This is going to decrease the pain by blocking the conduction of the pain impulses in a specific area. Therapeutic uses, parental administration. So once again, remember this is IV or IM. Anything with a needle that's going in intravenously. Dental procedures, minor surgical procedures, labor and delivery, diagnostic procedures. They can do regional anesthesia, so spinals and epidurals. Topical administration. This is going to be to the skin and mucous membrane disorders. Control laryngeal and esophageal reflexes prior to an endoscopy procedure. So this is going to help them relax more so they can get the scope completed and down to where they need to get it down into the stomach. Minor procedures, IV insertion, injections for pediatrics, wart removal. They can do a topical. Complications for localized anesthetics, CNS excitation, so the excitement, seizures followed by respiratory depression leading to unconsciousness. So you need to monitor for seizure activity, sedation, and mental status change. So you'd be looking for a decrease in the level of consciousness. Make sure you monitor their vital signs and respiratory status, and having resuscitation equipment at the bedside. Administer benzodiazepines like midazolam, diazepine to treat seizures. Hypotension and cardiosuppression. So bradycardia, heart block, cardiac arrest, common with spinal anesthesia due to a sympathetic blockage because we're blocking, remember, the fight or flight. So this can occur. Monitor your vital signs in ECG. Definitely get a baseline one. And then if manifestations occur, follow the prescriptions for treatment. Allergic reactions. This is going to be most likely to your ester type agents such as procaine. The clients who have allergies to one ester agent are likely going to be allergic to other ones in that class. Amide type anesthetics are going to have less occurrence of allergic reaction. Just observe for manifestations of an allergy to anesthetics. So allergic dermatitis, anaphylaxis, and then treat with antihistamines. Prolonged labor or fetal effects. It can decrease uterine contractility, which is going to prolong the labor. Local anesthetics can cross the placenta and result in fetal bradycardia and CNS depression. Clients who are in labor require caution when receiving the local anesthetics. So we need to monitor the uterine activity for effectiveness, and then obviously monitor the fetal heart rate for bradycardia and decreased variability. Spinal headache, monitor for indications of spinal headache. Remain flat in bed 12 hours post procedure. If they sit up, and as soon as they sit up they instantly get a headache, then that's considered a spinal headache. So you just need to have them laying bed rest flat. Urinary retention. This occurs more with your spinal anesthesia because it shuts everything down. So monitor your outputs, and then if your client can't void within 8 hours, you need to notify the provider. Contraindications, pregnancy risk category B, supraventricular dysrhythmias and heart blocks. Precautions, liver and kidney dysfunction, heart failure, myasthenia gravis. Locations: fingers, nose, and other body parts with end arteries. Do not add epinephrine, because epinephrine will add to, they add epinephrine to prolonged procedures to help the anesthetics work more effectively over a longer period of time. Gangrene due to vasoconstriction. Prevent self-inflicted injury until anesthetic effects wear off. So as long as you can't feel it, just try not doing anything until you're able to feel wherever you have the paralysis going on. Interactions are your antihypertensive medications. Nursing considerations. Injection of local anesthetics, your epinephrine, because it causes vasoconstriction, help prevent the spread of local anesthetics, prolongs the anesthesia. Preparing the site for injection, making sure that you monitor your vital signs and your level of consciousness, maintain your IV access, have resuscitation equipment on hand. And for a regional block, protect the area of numbness from injury until that numbness goes away. Continued nursing considerations: spinal and epidural nerve blocks, monitor during insertion, monitor for respiratory depression and sedation, monitor the insertion site for a hematoma and indications of any sort of infection. Determine the level of sensory block. So the dermatomes, you need to know which dermatome level that it's at, and if it keeps as it's wearing off, is it wearing off appropriately? IV fluids can be administered to compensate the sympathetic blocking effects of the regional anesthetics. They need to lie supine for 12 hours to help minimize the spinal headache. And then notify the provider if the clients are unable to urinate after 8 hours. Topical cream. Apply 1 hour before a routine procedure or superficial puncture, and 2 hours before a more extensive procedure or deep puncture. Apply to small surfaces, no wrapping or heat. Prior to remove the dressing and clean the area. NPO following oral administration until the pharyngeal sensation returns. This is usually approximately about an hour. And then monitor their first oral intake, making sure that they're not aspirating. And then they are able to apply this at home. So you just need to prior to coming in for a procedure, they can go ahead and apply this. Education: notifying the provider for indications of infection, increased pain, severe headache, sudden weakness, sudden weakness of the lower extremities, or decrease in the bowel or bladder control. Notify the provider for indications of systemic infusion, and then make sure you sanitize your hands before and after self-administration of the local anesthetic. So they make sure that they get it off of their hands.